Welcome to the next installment of the Master Clinicians video podcast series. It is my distinct pleasure to have a dear friend of mine and colleague, Dr. David Cohen, who was the co-founder of Teleradiology Associates and is currently a CMO of Experity Radiology, which is the largest teleradiology group servicing the urgent care industry. I've worked with him very, very closely. I am Dr. Frank Illuzzi. I am the Senior Vice President of Quality and Medical Education at CityMD, and I am very, very pleased to bring this next installment where we're going to be talking about chest x-rays in the urgent care setting with Dr. Cohen. So Dr. Cohen, thank you for joining us today, and I really look forward to this installment.
Oh, you're very welcome. I'm pleased to be here. I love talking about x-rays, and it's hard to find people that really want to listen to me very much about it, but you're definitely one of those people. You and I have been talking about cases for years now, so it's a pleasure to get to do this in a more official format.
Well, I think it's really important, that, we have this collaboration so we can highlight, x-rays that are often presented to urgent cares. And I think giving our providers the tools that they could systematically look at their x-rays to make sure that they're not missing any of the subtle findings that could be, lurking acuity or disasters for patients. If they can avoid that and identify these things on the front end, I think this would be a tremendous service that we can give our viewers out there. So I really appreciate you coming on board. So I understand you have a mini library of chest films that you wanted to go over, and without further ado, I'd love to just jump into those.
Okay, awesome. Let me go ahead and share my screen here. We'll get started.
Very good. So
right.
Before we get into actually looking at the individual films, maybe you could go and give our audience maybe your methodology of your approach toward looking at chest films, because I know I probably look at 15, 20 chest films a day. In my practice, when I'm working clinically, you must look at hundreds. How do you do this in a systematic way so you're not missing anything? Are there any pearls that you can give our audience and how you approach chest x-rays?
Sure. Excellent. Yeah, that's a great start. Urgent care x-rays, what I tell our radiologists when they join the group is that, it's pretty simple stuff, but it's not necessarily easy because you do have to pay attention to detail. And the best way to do that, I found, is to have a systematic approach, as you said, almost like a checklist kind of process. And for chest x-ray, what I like to do is start first by looking at the lung parenchyma, of course, and I find it easiest to look side to side and just compare to symmetry. So you start at the top and just look right and left. Is there anything that looks asymmetric from one side to the next? And you pay particular attention to between the rib spaces and areas that are called like the hidden zones. And that would be the lung apices, which is behind this first rib and clavicle area, and in the central aspect of the lungs, which is in the hilar region and these vessels. That's where lesions can sometimes hide, so you want to pay particular attention to those areas. Next, I go on to the borders, right? So those you're going to look all around the edges of the heart and the diaphragm and the mediastinum, and just follow these edges. You should be able to see these pretty clearly and sharply on a normal chest x-ray. You should be able to follow the hemidiaphragms all the way down to these costophrenic angles. And sometimes your only clue to pathology would be if you lose some of these borders and they get so-called silhouetted out. The next thing I like to do is always take a quick look at the upper abdomen and at the top of the chest where you're going to have your thoracic inlet. You should have a midline trachea, and you should be able to see the lung apices clearly on the film. And then, that's really my search pattern, and that'll get you, 98% of the pathology you can find on that quick search pattern. The last 5% is going to be really dependent on the history, and the history is super, super important. If we have a young patient and it's chest pain or pain on inspiration, we're looking right away for a pneumothorax, right? If we've got an older person and it's, it's cough and fever and pneumonia symptoms, we're paying a lot more attention to the lung parenchyma, looking for infiltrate. So really the history is a key part as well. And I can tell you in this case here, since we're starting off with one, this was a young patient. She was 26, came to an urgent care center and was complaining of cough and had some low-grade fever. And this is the film we had here. Frank, I don't know if you want to take a look at it yourself. We can
Sure.
play a stump Frank game here.
Put me on the spot, why don't you? Sure. Well, I mean, looking at it, I'm just seeing some maybe haziness on both sides. I'm looking for the asymmetry that you're talking about. When you pop this up, the only thing that really struck me, there's maybe a little subtle area of maybe a patch by the left scapula there, or maybe in the left upper lobe. But it was really, this isn't an overwhelming X-ray to me. But if anything, I'm going to point to that abnormality that I'm seeing in the left upper lobe there, and yeah, I'll bet on black, and and we'll see how it goes.
That's awesome. That's great. Yeah, it's tough to stump you for sure. That is the finding, and the key is really, as you said, looking left to right, looking for those asymmetries. This is particularly tough because it is partially obscured by the scapula. But this kind of—
Could you highlight that with your cursor?
Yeah, absolutely. So I'm kind of going around it here. It's
okay.
this patchy area of density there, and this sort of peripheral subpleural reticulonodular opacity turns out to be one of the most common findings that you'll see in COVID pneumonia.
You're right. Right.
The most common X-ray finding, believe it or not, and this is from a study that we published in conjunction with you over at CityMD, and the most common finding we found was actually a normal chest X-ray.
Right.
But when you do have chest X-ray findings, this is most often what you'll see, just this subtle peripheral patchy density.
Sure. At least early in the disease course, and then as it progresses, you can start seeing the bilateral patchy opacities.
Exactly.
But this is a common finding that you would see in a young patient presenting early on in the course of COVID if they have X-ray findings. I think without having experienced the COVID outbreak over the last several months, I probably would not have picked up that little patch in the left upper lobe. But one of the humbling things about this disease is it really is taught you to relook at things. And I think we had a discussion that I'm starting to look for cirrus clouds as well as cumulus clouds in my chest X-rays, because the COVID findings tend to be very, very subtle, at least in the outpatient setting. So anyway, very, very good. I appreciate you walking through that with us.
Good. Absolutely. Let me move on here to the next case. Okay, and this again, this is a woman who came to the urgent care. I believe she was 47 years old, and she again had some cough and low-grade fever, which is very, very common presentation for urgent care all times of the year. Not only during flu season, but that's one of the most common exams that we see is a chest X-ray for those types of symptoms. And in this case here, you can take a look again, Frank, and see if anything catches your eye.
Really, I'm looking at the lung fields, and it's again not particularly impressive. Maybe the right hilar area, maybe a little congestion there, but I'm not. This is an underwhelming film for me. I'm not ready to call a pneumonia on this one. I don't see anything.
Yeah. Well, that's this is much more subtle than the other one, but I just wanted to show kind of the spectrum of how subtle these can be. So this is again just a small area of peripheral infiltrate here. It happens to be in the left upper lobe.
Oh, wow.
That can really be anywhere. It can be on either lung or bilateral. And these days with those types of symptoms, you're going to want to look really carefully in these areas of the lung for anything that looks asymmetric. And in this case, it's just a small area right here.
Yeah.
For another case of COVID pneumonia.
It looks a lot more obvious when you point it out, I have to say.
Good deal.
All right, well, let's go to the next one. That's very good.
All right, so This young lady, 33 years old, came to the urgent care with cough, no fever. Cough had been going on for several months, no other prior medical history. And this is the x-ray that we got. So I'll give you a moment to look at it, and I just want to comment on one thing. As radiologists, we can get a little bit nitpicky over technique on exams, and reading from as many different locations as we do, we really see a gamut of types of technique and positioning and so forth. And this case came across, and just to point out, you could see how far down this image actually went. This is all almost to the iliac crest here. So that's never good. Not only does it increase the radiation exposure to the patient, but it really decreases sort of the resolution and magnification in the important field of view. If I mag this up just a little bit, you can kind of see that this is more how the chest X-ray should have been collimated to begin with.
Sure.
So I'm gonna leave it like that for you to take a look.
Okay. Well, I was going to comment on the technique because it definitely looks a little bit grainier, and maybe I'm getting older, but I have to put those on a little bit to take a look at this. The thing that popped out at me as I look at the symmetry going back and forth, the right perihilar area looks pronounced to me, and I don't know if that's those are lymph nodes or a vessel, or if that's an infiltrate or a mass or some sort. But that's what drew my eyes, was the right perihilar area. So there's some kind of abnormality there.
Great, awesome. That's a really good pickup. Sometimes this can be super tough. I'm going to give you, there's another view. I'm going to give you the lateral view to see if it helps you figure out whether you're looking at an enlarged vessel or if there's some node or mass there. This is the same patient, and this is the lateral view.
Yeah, to me, it looks more like a perihilar mass or adenopathy than it does the vessels coming off. But you're the expert, so I'm going to defer to you.
Yeah, no, that's great. That's exactly what this is, Frank. That's a good call. So on the lateral view, I'm gonna outline this lobulated density here. This is what we kind of call potato lymph nodes, right? So a lot of things in radiology are named after food, but
why do you think that is?
But this is very, very typical classic appearance for Hilar lymphadenopathy. And I'll just go back a second to the frontal projection. As you pointed out, you can see the asymmetry, this sort of nodular enlargement, but really sometimes this can be vessels. These can be enlarged vessels or even overlapping pulmonary veins and arteries that can look prominent. But when you go to the lateral view and you see this kind of nodular appearance, this is typical for adenopathy. And in a young patient like this, with that presentation, you start to think of things like sarcoid would honestly be the most common thing. You could have granulomatous lymph nodes like histo, depending on what part of the country you're in, or TB, and then of course lymphoma and malignancies as well.
Right. Any follow-up with this particular patient? Do you know what happened or what this ultimately was?
This was a case of sarcoid.
It was, okay.
All right, let's see. I think I can center this a little bit better. Okay, I'm gonna back this off a little too. All right, so this young fellow, this is one of those cases where the history is pretty important. So if you just started to look at this image without any history, you'd be going through your checklist and looking at the borders and looking for asymmetry and things of that sort. And it's overall a very clean looking X-ray. So on a busy day, as you said before, when you're moving through a lot of cases, right, some things like this, the pathology here can get missed. So the history is really, really key. And in this case, if nothing has popped out at you yet, looking at the image, I'll give you the history. This was a 31-year-old male with sudden onset of right chest pain with inspiration.
Right. So when I looked at this, my first inclination was this looks pretty normal to me, but looking at the symmetry and going all the way up to the apices, you can see that the apices are not symmetric. The apices on the right side are there's a paucity of blood vessels that you can see going up there. So you know, as an ER doc, this is the one you can't miss. I mean, you're in the urgent care, and if you miss this and you send somebody home, you know, and their lung collapses further, they can get in a lot of trouble. So this is something that you really have to be mindful of. And given that history of sudden onset in a young person, you have to look for that lung margin. And I think I can see it, you know, tracing down from you know, it looks like there's a small size, yeah, right there. There's a small, or actually a moderate size pneumothorax, and you can actually see the lung margin as you go all the way down that lateral edge, down in the intercostal spaces down lower on the right side. I think you can see the edge going down that way, all the way laterally. So this is actually a not subtle pneumothorax. This is something that really anybody in the urgent care needs to look at this film and see, you know, on first glance, it looks normal, but this is one that everybody needs to pick up.
Awesome. Good call. Well, I can see I'm going to have to bring some tougher cases next time, Frank, to stump you.
Are there any other findings that you see on this, like any asymmetry between the intercostals or any structurally that you can see that might be other hints to find pneumothorax?
Sure, absolutely. So this is the same case. I just zoomed it up a little bit here to try to accentuate what you described well as this white line here. This is the pleural margin, and if you look at it just really carefully, you can see actually all it is just a white line that extends down here. And this is the most important thing to notice when you have a pneumothorax, because the paucity of lung markings, that could be due to bullous disease, blebs. You can have sometimes an artifact called a companion shadow artifact from a rib, which can also cause in that case, it looks like a black line that can often be confused with the pneumothorax. So really, you want to see not only the paucity of lung markings, but make sure that you identify this white pleural line here.
Are there any things that you can do? A lot of us have digital, you know, PACS readers and stuff like that. There's you know, some techniques of changing the gain, going from negative to positive, in order to pick these out. Are there any tricks that you guys use, or is it just on the basis of, you know, you know, seeing what's normal, what's abnormal, and just being very, very meticulous and trying to look at, you know, each of the different lung fields to make sure that there's symmetry in the lung vessels going out to the periphery?
Yeah, you know, not really for me. I've tried a bunch of those different techniques, you know, inverting the black and white scale and various things. But to me, honestly, it's just paying attention to history, and then, you know, of course, zooming up. And you know, we spend all day long zooming in and out, changing window level. You know, it's a lot of very active manipulation of the image presentation during the review process, and you know, and that's super important. So you have to make sure that you're doing that on every case, really magging up and zooming and panning, and it's a very active kind of search process. And as long as you're doing that, you know, you don't need any more tricks. You know, these things will be visible.
Can you also speak to the need for the high resolution, high mag unit to look at these films? Because I'm obviously I'm remote because of the whole COVID thing right now, and I'm on my Mac at home, and you know, the line is a little subtle. It's there, and I can see it, but I can see the paucity of air in the apice much better than I can see that little white subtle pleural line. I know at the clinic, you know, we have high res monitors, so we can look at our films on a high res monitor. I know many places, you know, one of the hospitals I used to work at, you know, the CFO was arguing that we didn't didn't need high-res monitors in the ER because, we weren't looking, for breast nodules or something like that, and we didn't need the same radiology grade films. Can you just speak to that? Because there's a lot of people out in the community that are, looking at films and looking at these x-rays. A lot of people like looking at their x-rays on a laptop or a desktop that might be, anywhere in the unit. Can you talk about the need for high-res monitors and how important it is, especially in light of this particular case?
Absolutely. Yeah, that's crucial. I'm glad you brought that point up. And it's particularly important for x-rays, right? So the resolution that you get on your monitor is much more important in x-ray than it is for CT or
Right.
MRI or the other modalities. And for x-ray, it's recommended you have at least 4K monitor. And New York State and New York City is the only state in the nation right now that actually has a requirement, and they enforce it pretty strictly. They have inspectors that come around, as you know, and they make sure that
Right.
the radiologists are in fact using monitors of that quality. And these are medical grade monitors. For mammography, that's the only specialty where you need a little higher. You need 5K, but 4K for X-ray at a minimum. And in addition, I'll say, the other thing that's really, really important, almost just as important, is to have a really large monitor. I see people, trying to read these on laptops or tablets and other types of small screens. It's brutal. You really need at least a good 27 inches at a minimum of a monitor in portrait mode with 4K. And it's got to be, there's a lot of other things that are important. For example, the ambient light in the room, when you're in your reading space, it needs to be dark and the windows need to be closed. You have to have the ambient light down, because that again will really impact the contrast of the shadows that you're seeing. And along those same lines, sometimes we have urgent care centers that'll send images that have been sort of manually cropped with almost like a white framing. And any kind of extraneous light or whiteness around the image itself will take away from that contrast. So that's another thing you really want to avoid in your own centers, not your guys, but we see a lot of it from other locations where they have some things like that take away from the image quality.
Well, thank you. No, I appreciate you sharing it. I mean, obviously, you don't want to miss a pneumothorax, so that was a good case to go through all that. Huh.
Yeah. Well, here's
Well,
another area.
yeah. And what was the history on this one?
I'll give you a little history here. This patient presented again with sudden chest pain, no known trauma. It had been going on for about 36 hours, no fever.
Yeah, I mean, when you're looking, again, I'm looking at the lung fields, and the lung fields actually look quite symmetric. The space between each of the ribs looks pretty symmetric as well. The thing that caught my eye on this one is along that left heart border, there is this lucency that goes all the way down immediately, along the left heart border. And I can almost imagine it maybe on the right heart border a little bit, but that on the left heart border going all the way up and actually extends into the mediastinum. I don't know if this is a pneumomediastinum or if there's a pericardial effusion with some fluid tracking up, but there is a lucency around that that left heart border there.
Nice call. This is another case. I'm trying to highlight a few cases where got air where it's not supposed to be, right? So
it's air.
That's right. That lucency right there. And again, you can see this thin white line. In this case, it's the pericardial lining. That's very important to recognize. And you've got pneumopericardium here. And in addition, it's tracking up into the neck. And if you look up here.
Oh, wow. I didn't see that. Yeah, look at that.
You see some patchy lucency here. And that's emphysema in the soft tissues of the mediastinum and the neck. And sometimes, as you know, it can extend out into the shoulders and all into the base of the neck, but it's right up in there. So you can have some crepitus on exam and so forth. But these are not common in urgent care, but we still see I'd say a good dozen or so every month. So really something to be aware of. And this falls into that bucket we talked about before in the search pattern of following the contours and looking for the heart borders. And if you were following that search pattern and with that history, you know, you undoubtedly would see that lucency over there.
Wow, that's an impressive X-ray. Any
Yeah.
follow-up? Was that just you know, somebody who had asthma and they just coughed and they popped something, or what was the history here?
Yeah, that's almost always the history that we get, kind of with urgent care being not super high acuity place. It's usually just some increased Valsalva pressure, some coughing, or some sudden impact that causes a little small perforation there.
Wow,
And that's the case here.
very good.
Cool. All right. Moving on here.
Ooh.
Yeah, when they get older, it gets a little trickier. Huh? There's a lot more going on in the chest.
there's a lot going on here. Yeah, I mean, there's an elderly patient, obviously.
Yeah.
There's some chronic interstitial scarring. I mean, there's just bilateral. I don't know if those are vessels or a couple of nodules up there. Um, yeah, looking around, maybe a little COPD, but I see maybe, I think those are two nipple shadows that I'm seeing on the bottom. They're not infiltrates on both sides because they look
Yeah.
symmetrical over there. You have a little nugget of air underneath the right diaphragm, right in the right costophrenic angle too. That might be the finding you're asking me to find here. But there's a lot going on here.
Yeah.
Why don't you walk me through this one?
No, that's great. Yeah, you know, and that's the problem. You get some older patients, and a lot of these sort of incidental findings can really be distracting. You know, if you let yourself get sidetracked, you know, in some of this miscellaneous stuff, it can cause you to miss out on what's really significant here. This is a patient that had some coughing and abdominal pain, actually. And what you see in the lungs, as you said, is a little bit hyperinflated, nothing major here. There's a little granuloma, calcified granuloma here. The interstitial markings are a little bit prominent, but I really wouldn't make much of that. This is some breast shadow bilaterally, you know, no infiltrate there. You notice you can see the heart border really well. When you go out and you look at the diaphragmatic borders, as you mentioned, there's just a sliver of lucency here. And you know, I'll tell you that this is a tough call to make. You know, I'd like to say that it gets diagnosed every single time, but it's a tough one. You know, you got to be paying attention. You got to have a good quality image. And this in fact was just a sliver of free intraperitoneal air. And this patient was very sick. This patient went to the hospital. They had a perforated viscus, and they had a really difficult medical course. But this was in fact the only finding at chest X-ray and on presentation was the sliver of air. So, you know, these are the types of things, as you mentioned, with pneumothorax that, you know, you just don't want to miss. They're really important. They're not that common, but you know, you got to be aware of them. And when you're doing your search pattern, you know, those are the things you got to be on the lookout for.
Yeah, and to talk about technique, I mean, it's very important that you get the, you know, the sulci of both costophrenic angles right there. And you know, too often you see, you know, something gets chopped off, especially if the lungs are
Oh, yeah.
hyperinflated, and you
Yeah.
miss that corner, and it's like, oh, is that really? Do I really have to, doc? Do I have to really shoot it again? Because you know,
Yes.
we got, you know, no, you need the entire lung fields, and you need to see the entire diaphragm, and that's just that's a perfect teaching case right there, just to teach, you know, adequate technique, how you need to get the entire lung field onto the screen. So
Yep.
yeah,
Absolutely.
this is a scary X-ray, I have to
Yeah.
say. This is
Okay. Seeing the same
not
thing.
one you want to be taken care of
Uh-huh.
in the urgent care.
Absolutely. All right, Frank.
Okay.
Here we go.
Huh. Well, let's see. It's not as scary as the other one. I mean, when you look at it and, you know, with your technique of going through the lung fields first, and I see pretty good symmetry there. And, you know, I'm looking at all the borders, the heart borders and you know, the diaphragmatic borders. That looks pretty good. Looking at the periphery there.
Yep.
That looks pretty pretty good. That looks pretty normal. The vascularity is a little bit prominent, but it's equal, and I don't think I can make anything out about it there. No free air. The bones look okay. I don't know, maybe the
Awesome.
trachea is a little bit deviated, but I don't know what to make of that. This looks pretty normal to me, actually. So I don't know. You stumped me.
No, no, actually, well, I love listening to your search pattern, how you go through that. You'd be surprised how few people really are systematic. Sometimes people just take a very passive approach and look at the film and kind of wait for something to catch their eye. But I love the way you're going through that process, going through all the different things that we talked about. You look at these Hilar vessels, how straight and smooth they are. But the finding was actually something that you touched on in this case. It is in fact at the thoracic inlet there, where you see that trachea deviating to the left. That's, as we discussed earlier, should be part of the search pattern. That's not a normal finding. Sometimes it can be artifactual if the patient's head, is really turned to the side and the positioning is not good. And in this case, the clavicles really look pretty symmetric in relation to the spine. So we got to think that this patient is pretty straight, in which case that finding of the trachea deviating to the left is the pathology there.
Really?
And, most often it can be due to any mass or aneurysm or lesion in the neck, but most often it's a thyroid lesion. And as you know, those patients can present with cough or dysphagia.
Sure.
And that was the case here. And the follow-up would be an ultrasound, and that was what was subsequently done. And she had a thyroid nodule there.
There's a big thyroid nodule in order to deviate the trachea like that. Wow.
Oh yeah. Yeah. These, as you know, can extend all the way down into the mediastinum and
Sure.
really compress the trachea even sometimes and narrow it. So,
yeah.
Not life-threatening like the previous cases, but certainly something you'd want to pick up when you have the opportunity to.
Just as an aside, you didn't get a soft tissue neck on the same patient, did you?
No.
All right. That would have been interesting. Okay.
Yeah.
Well, very good. You got me.
Well, sort of, halfway. Let's see. All right. So this is
a little, the technique is a little bit different. I mean, this is a little tough to read here.
This might be our last case, I believe, but
okay.
I'm trying to point out things not only that are really really dangerous and important not to miss, but also some kind of tips and tricks and things that can be foolers or things to be aware of. And this particular case, she's a pretty small woman, in her 50s, came in with it. Really, our most common history is just kind of cough.
Right.
Didn't really have anything else going on clinically. She's a very, very small person. She's very thin. So you do kind of get an accentuation of the markings where the breast tissue and the overlying shadows are pretty prominent. But looking at this, Frank, is there anything that you would be otherwise concerned about?
I'll be honest. I'm looking at it, and again, I think the lung tissue is symmetric. I think the borders look pretty good. I mean, I guess if you have to twist my arm, maybe the right heart border is a little obscured. There might be a little bit of an opacity there, but that's subtle. I mean, I'm really looking for something in this film. So I'm going to stick with that. Okay.
All right. Good. Well, kind of give you a pass there. That's the point. The point here is there actually is no pathology here, but this is I'm like pass you there, but the type of case where often people will get tripped up here by this right middle lobe area because it is a little hazy. There's no right heart border here. I mean, the right heart border should be right here. That's where it's sitting, but you don't see it.
Right.
You might even say that this kind of medial portion of the right hemidiaphragm is not sharp, and it just kind of looks hazy. And oftentimes, this gets questioned as an infiltrate, and it's not. It's a normal variant, typical finding. And I'll show you the lateral view. If you ever see something like this and you're wondering if it's real, you go to the lateral view,
and it's clear.
Yeah. it's clear. There's nothing over the heart at all. And you
Yep.
can see here the lower sternum is indenting in. So this is a pectus excavatum deformity.
Sure.
And
Is that
that
what
was,
I'm seeing on the front on the AP view, on the PA view?
yes, exactly. This will typically, anytime you get a pectus deformity, this is what's going to cause this increased density and sort of obscure the right
I
heart.
got you.
Sometimes it could be a lot more pronounced, but just to be aware that this could be a really a mimicker of infiltrate, and the importance of making sure you have a good lateral view and recognizing a pectus deformity as a cause.
No, that's a really good tip. I'm sure that I've seen that, and I probably overcall the right middle lobe because of it. So I appreciate it.
Yeah, awesome.
All right. Well, I think that was the last chest X-ray that you had today, correct?
Yes, it was. Yep.
Well, David, I definitely appreciate you going through these. I find it very enjoyable going through X-rays just one-on-one, and I'm very happy that you agreed to sit down at least for part one of this and going through the chest X-rays and giving our audience basically a pathway of looking at their chest X-rays in the clinics themselves and giving them some pearls, so this way they can avoid making some errors and catching some of the subtle findings that make them really top-notch clinicians. So I appreciate your time, and I look forward to inviting you back to go through the long bone films and doing the same thing shortly.
Sure, I would love it. Thank you. Thanks for having me today, Frank. Appreciate
Well,
it.
thank you very much, and to our audience, I hope you enjoy that as much as I did, and I hope you picked up a couple of pearls as I did in reading your chest X-rays and being a better clinician. So until the next time, this is Dr. Frank Illuzzi signing off from the Master Clinicians podcast series.
Bye-bye.